Hello, everyone. Welcome to today's phlebotomy webinar on blood cultures. This is Sierra Tollefson, an education specialist for Mayo Clinic Laboratories. Our presenter today is Dr. Nick Streck, a clinical microbiology fellow in the Department of Laboratory Medicine and Pathology at Mayo Clinic in Rochester, Minnesota. Just a couple of things to remind everyone of before we begin today. There will be a question and answer session at the end of the program. You can submit questions online via the Q&A icon in Zoom. Please only use the chat function for any technical issues. Today's program is being recorded and will be posted to our website in a few weeks. And now I'll turn things over to our presenter.
All right, thank you, Sierra, and again, welcome to everyone. Thank you for joining us today. My name is Nick, and I'm one of the clinical microbiology fellows here at Mayo Clinic. I've primarily had background and training in microbiology laboratory practices. So the goal of this webinar today is to try to give you some insight into what goes on in the laboratory and really tie that back to the blood culture collection process to try to highlight some unique aspects of blood cultures that really make the collection process such an important piece and component of the results that we're reporting out to the healthcare providers. So I don't have any relevant financial or disclosures or off-label usage, so we can go straight to the learning objectives. As we go through these slides, these are the key points that I'm going to highlight, and hopefully you'll be able to take away from today's discussion. After reviewing these slides, hopefully we'll be able to describe the clinical importance of bloodstream infection. We're going to spend some time talking about some of the terminology and key distinctions between some of the things that the laboratory can identify versus what the patient may be presenting with. After this presentation, we'll be able to define the criteria necessary to recover clinically significant pathogens. Again, because this blood culture collection process is unique compared to some of the other blood testing that is performed for patients, there's some key things that we want to spend some time talking about and looking into. You'll be able to recall the collection approaches that help reduce blood culture contamination, which I believe everybody tuning in, the participants here today, are familiar with this challenge that multiple teams associated with patient healthcare are actively working toward to reduce that contamination rate. And then finally, throughout the talk, we'll be highlighting points where you'll be able to recognize the importance of the phlebotomists or any of the blood collecting staff and their importance in quality blood culture collection and also the reporting of results from the microbiology laboratory. All right, I'm going to start by talking about some of the terms that are used associated that are relevant with blood cultures and the reporting as well as the patient presentation and symptoms. The first thing that I want to cover is the term bloodstream infection. The definition of this term is that this is describing the presence of pathogenic organisms in the patient's blood. And we can be more specific than that. We can describe this if the patient has bacteria that's present in their blood. You might hear the term bacteremia. If there are mold or yeast present in the patient's blood, you might hear the word fungemia described. And as all of the participants, I'm sure, are aware that are tuning in today, typically a healthy patient would not have microorganisms present in their bloodstream, but there are a variety of reasons why this may occur. One of the common reasons that this can happen is through to some sort of invasive event that introduces microorganisms either from the environment or other parts of the patient's body into the bloodstream. This can happen through surgical or other invasive procedures, as well as some sort of traumatic incident that may introduce these microorganisms. The presence of organisms in the bloodstream can also be an important indicator for healthcare providers that there's an infection in another place in the patient's body, something like an internal abscess in another area of the patient's body that's constantly releasing microorganisms into the bloodstream. So finding organisms in the bloodstream can also be an indicator that further downstream workup needs to be performed. And also an important point when we find organisms in the bloodstream, particularly dependent on the patient and also the organism that's identified. It can also be an indicator that further investigation needs to be performed to look for things like endocarditis, infections in the heart or blood vessels. So finding the presence of microorganisms can be a key indicator that further investigation can be performed in these patients. And I want to make an important note. We're going to switch to a clinical term here on the next slide, more describing kind of patient presentation and symptoms. But I do want to note and just ask you to be aware as we go through these slides that the bloodstream infection is really what the microbiology laboratory, this term is what we are working on to identify microorganisms that are present in the blood. And that's a key distinguishing factor between the other terms that we're going to discuss, because it can sometimes be difficult to assign clinical importance to the work that is being performed in the laboratory, which is why the blood culture collection process is so important. So that's bloodstream infections. I then just want to briefly cover the term sepsis, which is something that gets used quite a bit. This is a definition here from mayoclinic.org, but this term is really used to describe more the overall presentation and more systemic response that's occurring in a patient in response to infection. The immune response that is triggered following some sort of infection or introduction of microorganisms into the bloodstream results in a release of inflammatory and other immune signaling molecules that are important for helping to control the infection, but also have off-target effects on this patient that can end in very serious harm to multiple organ systems and many symptom presentations, a variety of presentations that we're going to cover in the next slide. And this is really triggered by that rapid growth of microorganisms in the blood that really creates this large immune response that can have these off-target effects. And it's a very serious condition, as we have pointed out here. It's a life-threatening condition, and if it's allowed to progress, you can go into very even further serious situations such as septic shock, which have very high risk of mortality, even higher than the initial presenting symptoms that a patient may have. So it's important that these patients get the adequate care and response from healthcare providers as soon as possible. And that can be a challenge for healthcare providers because the symptoms of sepsis, which I have highlighted here on this slide, can be very systemic, and in cases when you may not have a very severe variety of symptoms that are presented by the patient, it can be difficult to identify, particularly because we don't have a single laboratory test or a single symptom that we can look for to identify in these patients. You can see some of these: fever, elevated heart and respiratory rate, mental status changes. You can see many of these things in a variety of conditions. And so there are different scoring systems that are used by our healthcare staff to help identify probable and presumed cases of sepsis, but it can be a difficult presentation to identify depending on the patient. And it's important, though, that we do everything we can to identify and treat these patients as soon as possible, because it's a very severe medical emergency for these patients. You can see some of these stats here in the US. More than a third of hospital deaths are attributed to sepsis and the progression to septic shock. And it's the most expensive condition in US hospitals. You can see the annual spending that's estimated there. And that's, again, because these patients require a lot of attention, prompt treatment, and utilization of a lot of resources on our healthcare system to help mediate this medical emergency. And that prompt treatment is important because we know through a number of studies that the response time, in a variety of ways that this can be measured, but the response time is really tied to the outcomes for this patient. One of the things that has been studied, I have a snapshot of that data here, is the amount of time it takes to administer the first antibiotic in these patients, and that correlates with the predicted hospital mortality. In other words, the longer it takes to administer that first antibiotic, the higher the predicted mortality is in that patient, really highlighting the need of the prompt treatment and this really being a life-threatening medical emergency. There are also other data that have been collected, more relevant specifically to blood cultures, that's shown that the amount of time that it takes for blood cultures to be drawn and transit to the microbiology laboratory, that also correlates with the length of time that patients are in the hospital. So the longer that it takes, the longer that it takes these blood culture bottles after they've been collected to get to the microbiology laboratory to initiate incubation and testing is associated with longer hospital stays. So really tying back that fact that the importance of blood cultures on this medical emergency, and the need really for prompt reaction and testing to help these patients. So with those terms, though, we can now kind of switch now to speaking specifically about blood cultures and talking about kind of some of the unique aspects associated with their workup and how they fit into the ability to help the healthcare staff and healthcare providers in responding to patients that are presenting with symptoms of sepsis. So this is just a very broad slide to highlight some of the key purposes of blood cultures, and we can kind of think about these as we go through the next slides and think about how that the blood collection process can help make sure that we achieve the purpose that we're attempting to do with blood culture testing. So the first thing that it can do, I mentioned that some of these symptoms of sepsis are very nondescript, can be present in a variety of disease presentations. So the first thing that blood cultures can do can determine if a bloodstream infection is actually present in these patients. If we do not detect microorganisms in the blood, it may prompt healthcare staff to investigate other causes of the symptoms, and also can help promote good antimicrobial stewardship and prevent the overutilization of antimicrobial agents when they are not necessary. Now, if we do see the presence of microorganisms in these blood cultures, the further workup that the laboratory can do can provide really critical information to make sure that these patients are being treated appropriately. The identification of the organism is the first thing that we can provide to the healthcare providers, the team taking care of the patient. And the identity alone can be important in helping to identify the source of the infection. We talked about where some of these causes can occur to um, result in bloodstream infections. And so identifying potential sources of these infections, other places in the patient's body, prompt further workup. And then also, as we do further testing, not only with the identity of the organism, but with further downstream susceptibility testing, we can also help contribute to the appropriate use of antimicrobial therapy. Not only making sure that the patient is being appropriately treated, but also narrowing the spectrum of antibiotics that are being used following empiric therapy, so that we make sure that we're promoting good antimicrobial stewardship. So for blood cultures to really achieve these purposes, though, we do have to make sure that the quality of specimen that we're receiving in the laboratory is as high as it can be, so that we make sure that we're reporting relevant results back to the healthcare team. And so one of the first things that we like to highlight when it comes to the quality of specimen is to highlight volume. That is probably the single most important factor when talking about blood culture quality, is being sure that we have received adequate volume to deliver this testing and achieve the purpose of blood cultures. So relative to other blood testing that might be performed in this patients, we're really looking for a relatively large amount of blood to perform this testing. There have been a number of studies that have looked at the performance and sensitivity of blood culture testing, and really the adequate volume is somewhere around starting at about 40 mils of total blood collected. We can detect the majority of bloodstream infections, but we can actually increase the performance, increase the sensitivity of testing, particularly in certain at-risk patients if we really get closer to the 60 mils of blood. And so at Mayo Clinic Rochester, the optimal volume that we're really shooting for and educating our healthcare staff is that we would really like to get 60 mils of blood total. And that is quite a lot of blood. And the reason why we need that is because some of these infections, these bloodstream infections, can have a very low number of organisms present in circulation. You really do not need a large bacterial burden in the blood to make a patient very sick and have this very, very life-threatening septic presentation. So if we don't get a high, this adequate amount of blood, it's very likely that we won't be able to detect these low numbers of organisms that are present in circulation. So this is a quality monitor that healthcare institutions track very closely, is being sure that we're receiving this adequate amount of blood, whatever is set for individual institutions that we're aiming to make sure that we receive, and that's communicated back to different locations and staff that are performing these blood collections to make sure that we're doing everything that we can for our patients to get that amount. Now, on the other side of that, it does seem that data exists that over 60 mils in most patients really is going to very, very minor improvements in the performance of these blood cultures. And so we do also monitor for overdrawing of blood, because that really does not seem to make any improvements for patients and could potentially cause more harm than good for the patient. So we're really shooting for that kind of fine line of receiving enough blood without taking more than necessary. So I've highlighted here some of the collection processes that we do at Mayo Clinic Rochester. It might be slightly different from institutions, so I do encourage all the participants to make sure that they refer back to their own guidelines. But the way that we achieve the 60 mil optimal volume that we are shooting for is that a standard collection in our would be 30 mils of blood per needle stick, and we actually distribute that 30 mils of blood into 3 adult blood culture bottles. So that would be 10 mils per bottle, which is the recommended volume for the system that we're using in our microbiology laboratory. I will point out, just as we're on this slide, I'm talking here about adult patients that we're looking for 30 mils of blood per draw. For our pediatric patients, depending on the age, that might be too much blood than what is recommended. So there are a lot of weight-based recommendations and volumes that can be utilized. There are many resources out there that let the collecting staff know what would be an appropriate amount for our pediatric patients, and following those guidelines is the recommended way. We also have pediatric bottles that are able to accept those smaller volumes for these patients. I do want to note there is a slight misconception about the pediatric bottles. They're designed really for our pediatric patients to receive those smaller volumes, but there's a misconception that they're actually designed for higher sensitivity and ability to detect organisms better. That's really not the case. There have been comparison studies where the same patient has had pediatric and adult blood culture bottles drawn. It doesn't actually increase the sensitivity. So if you have an adult patient, we really want to actually get that full amount. But drawing a smaller amount and putting it into a pediatric bottle really isn't going to provide the best sample type and specimen volume for us to be able to identify for microorganisms in the laboratory. So with individual draws here, we get these 30 mils of blood distributed into 3 bottles, and then we ask for 2 separate draws to be performed. 2 different anatomic sites have this 30 mil collection, and that's how we end up getting the 60 mil total. And this 2 separate draws is important. We'll spend a little more time in a couple slides talking about how that helps the laboratory distinguish between a true pathogen and possible blood culture contaminant. So I see a couple questions here talking about the bottles. I do have this next slide here that I was going to walk through and talk about just some of the terms and the bottles that are collected. Again, I do want to highlight that this is the process for blood collection at Mayo Clinic Rochester. We identify we collect 3 blood culture bottles per needle stick, but that's really not the norm in most healthcare institutions. Most are going to be doing 2 bottles, but I have this set up here, and I just want to describe some of the terms that are used. We get some confusion and quite a bit of questions that get asked in our laboratory and among the other microbiology fellows about bottles versus sets versus orders. It can cause some confusion as to what we're talking about. And so just to make sure that everyone is on the same page, when we talk about a set of blood cultures that are being collected, we're referring to a single needle stick. And from that needle stick at Mayo Clinic Rochester, we're getting 3 blood culture bottles, that 30 mils of blood distributed into the bottles. We collect 2 aerobic bottles and 1 anaerobic bottle. And I'm going to describe those here in the next slide. In many cases, a single aerobic and a single anaerobic bottle is what's collected in many other institutions. So that's one set, but for a total order, we would like to see at least 2 sets. In some cases, a third set for certain patient populations. A third set might be utilized, but an order would be at least 2 of those sets that were collected for a total at Mayo Clinic Rochester, 6 blood culture bottles. From 1 anatomic site, we would get that 30 mils, and then from a second collection, we would get that second 30 mils that are collected. Okay, and so this collection process, we end up getting quite a few questions about surrounding this collection process, and I tried to kind of summarize some key points here that I wanted to go over and just highlight to summarize some of these questions. One of the common questions that we get, and I highlighted some data as I talked about sepsis and the need for prompt treatment, is we get questions about drawing blood before and after antibiotic administration. We know that following antibiotic administration, a lot of the empiric therapy that's administered for these patients is very broadly acting, broad spectrum antibiotics that can have an effect on our ability to culture organisms if blood cultures are collected after an antibiotic administration. So we may end up falsely reporting negative blood culture results due to the fact that they were collected after the antibiotics. The antibiotics are working, but it doesn't give the clinical team any further information on what was really causing the source of the patient's symptoms. So best practice is that whenever possible, we want these blood cultures drawn prior to antibiotic administration. And the question that we sometimes get is that, if there's going to be a delay in our ability to collect these blood cultures, we know that antibiotic administration promptly to these patients is really important for outcomes. What is an unacceptable delay in antibiotic administration if there's going to be a delay in blood cultures? And for the past few years now, we have had some guidance from the Surviving Sepsis campaign that has provided some sort of guidance on timing of this. They recommend that in patients that have probable or likely sepsis, that an antibiotic should be administered as soon as possible, but really within an hour. So that's sort of the guidance that we have been providing, and now that we have that recommendation, those guidelines are helpful to utilize kind of as a time point and when trying to determine what an appropriate delay is. So really within that hour, if blood cultures can be drawn, that would be best practice. If there's going to be a more significant delay than that, we don't want to delay antibiotic administration, again, because that is tied to the outcome of the patients. We do also occasionally get questions about arterial versus venous blood collection and whether or not there's better performance in our blood culture assays depending on what is collected. There have been multiple studies that have really shown that there is no difference. And so because of the complications associated with arterial blood, and also given the fact that there's actually been increased reports of blood culture contamination with this collection, that we recommend that venous blood, the performance of that is going to be as good as arterial blood collection, so that is not necessary. We also do get quite a few questions about collecting the blood cultures during fever spikes, and I think that comes from the fact that there are some microbiology testing, particularly in some of the parasitology testing that can be performed, that there are recommendations for collecting samples during fever spikes that increase the performance of the test. That really hasn't been borne out in studies that have looked at blood culture performance. So really more importantly than trying to time collection around fever spikes, the important recommendation that we give is we want to get these collected as soon as possible, and we really want to focus on getting the appropriate volume collected promptly rather than trying to time that around a fever spike, because that doesn't really seem to affect positivity rates. And then we do get questions. We are aware all of the recommendations that we give are ideal, assuming that we can get all of these things from patients. But we know that individual patients, there can be difficulties in collection. Patients can have multiple intravascular devices that might be we might require those to actually draw the adequate blood. The recommendation that we give is we want to at least make sure that one blood culture set is collected from a peripheral venipuncture, and really that is because of the fact that these intravascular devices, these lines, are in communication contact with the skin. We have a lot of bacteria that colonize our skin and then are very well adapted at colonizing the material of these intravascular devices, and so we can have trouble if the only blood that we get is collected from these devices. Really have trouble identifying whether the organisms that we're seeing represent a true bloodstream infection, or these are organisms that have colonized these devices. So we really want to see one peripheral venipuncture whenever possible. And then we do get questions about transport of bottles to the laboratory. I think this comes from some of the regulatory agencies. We have checklist items that say that these need to be transported within a reasonable amount of time or as soon as possible. The reason why that verbiage is a little vague is we don't have great studies that have really identified the amount of time, the acceptable time frame for getting these bottles to the microbiology lab to initiate testing. What we do know, though, is that the transit time, as I mentioned, is tied to patient outcomes. So we do want these to be, whenever possible, we want to get them to the microbiology laboratory as soon as possible so that we can get these bottles in appropriate incubations and initiate testing as soon as we can. Another point is that we shouldn't refrigerate or freeze during transit these blood culture bottles, because that does impact the viability of the organisms that may be in the bottle. So we want those just at ambient temperatures. Okay, so I do want to spend a little bit of time. I mentioned briefly as I was talking about the terms of blood culture collection, sets, bottles, and orders, that we collect blood into aerobic and anaerobic bottles. Then I see some questions in the Q&A about fungal bottles. So it seems that everybody is aware that there are different types of bottles that are available for blood culture collection. In general, the composition of these is quite similar across all of the bottles. They're really designed to have a large amount of growth factors and nutrients that support the growth of microorganisms. They have anticoagulants as well as resins and activated charcoal. These are things that can help increase the surface area that's available for microbial growth, can help inactivate some of the activity of antibiotics. All of these things are present in the broth of these blood cultures, and they are most enhanced, and their ability to help support growth is really dependent on a good broth to blood ratio, which is why we have certain recommendations for the optimal amount of blood that should be put into each bottle. Getting that appropriate ratio helps facilitate the activity of the broth. So this is a pretty general idea that this is across all of the blood culture bottles. So a common question that we get is, why do we need different bottles? And the fact is that there are many organisms that can be found in the causing bloodstream infections, and the diversity of the organisms that we see unfortunately requires a different, slightly different environments to actually facilitate growth. And one of the big differences is the presence or absence of oxygen. So we have certain bacteria, things like E. coli and Staph aureus, that will grow in environments, including blood culture bottles that do contain oxygen. But then we have other organisms like Clostridium or Bacteroides species that will only grow in bottles that do not contain oxygen. And oxygen is actually detrimental to their ability to grow. And while there is some cross ability for some organisms to be able to grow either in the presence or absence of oxygen, the fact of the matter is that there are certain organisms that can be found in the blood causing bloodstream infections that will only grow in one of these bottles or the other. And so to make sure that we are casting a wide net and being able to culture and identify as many organisms as possible that could be causing the patient's symptoms, we have these two bottles that are commonly used, both aerobic and anaerobic bottles that provide an adequate environment to culture these different organisms. Those are generally the routine culture bottles that are set up for different healthcare institutions, these anaerobic and aerobic bottles. There is a third bottle, and I've seen that mentioned in some of the questions here, that is optimized for fungal and mycobacterial growth. They have slightly different composition in them to help support their growth. That's generally not part of the routine collection process, but there are certain patients that may have risk factors or other clinical presentations that may cause suspicion for a fungal or mycobacterial bloodstream infection. And so this is another bottle that is available that can be added and is something that might be used in certain practices. So once we have gotten these bottles collected, and they've been sent to the laboratory, I want to talk about kind of the downstream, what happens in the laboratory, the downstream work that occurs to give you an idea of why we might need some specific aspects to this collection process that is different than some other blood testing. So we are constantly in the laboratory looking for the receipt of blood culture bottles. We recognize this as an urgent and critical test that we want to initiate proper incubation and testing as soon as possible. So the laboratory staff will identify these bottles as soon as they come into the laboratory and get them in the appropriate incubation environment. There are a number of blood culture incubation instruments that are available. We have a picture here of the one that's utilized here at our microbiology laboratory. But all of these instruments now continuously monitor the bottles for growth of organisms. And they do this usually by identifying some sort of byproduct of bacterial growth in the bottles, whether this is through gas release or pressure changes within the bottle. But this is a continuously monitoring system. So as soon as these indicators are identified in an individual bottle, the microbiology staff, the technologists working, will be notified by the instrument through lights and alarms, depending on the instrument you're using, that we have a positive blood culture bottle that needs attention. And this is a picture here. You can see this bottle is what is being flagged by the instrument as positive and initiating downstream work. And because of the critical nature of sepsis and the urgency of bloodstream infections, we are monitoring this 24/7 in the laboratory, so that as soon as a blood culture is identified as having bacterial growth, we can initiate the downstream workup to provide information to the healthcare providers. And the first thing that can be performed when there is a positive blood culture is the performing of a gram stain. So this is for those that are not familiar. This is something that can be performed immediately after a blood culture is positive. That blood culture broth and blood mixture can be put onto a microscope slide, and a gram stain can be performed. And the purpose of the gram stain is really to provide a general overview and description of the organism. There are certain groups of organisms that after the completion of the gram stain procedure will be stained differently depending on the composition of their cell wall. There are certain organisms that will take up the crystal violet that's part of our gram stain procedure and will end up purple at the end of the staining process. We call those gram-positive organisms. There are other organisms that will take up the counter stain and end up being pink or red, is the typical counter stain that we call those gram-negative. And so even just by identifying these broad characteristics of the organism, this can be very helpful to the healthcare team to make sure that they are treating with appropriate antimicrobials as we wait for further information. And these are two examples of gram stain images here. You can see on the left, we see some purple, more circular organisms. This was reported out by our laboratory as gram-positive cocci resembling streptococcus. So we can call that to the healthcare provider, and they can immediately start thinking about things like streptococci as well as enterococcus, and being sure that they are treating appropriately. On the right, you can see another organism that's staining gram-positive, but relative to the other image, it's much bigger. It's a little more oval shaped. You might even be able to see some budding that's coming off of the other cell. And this is yeast, and so this can be reported to the healthcare provider as well as organisms resembling yeast, and the healthcare providers can then make sure that they're treating with appropriate antifungal therapy. And this is a very rapid test. We can, as soon as that blood culture is positive, this can be reported out quite quickly after that positive result. So it's a result that we can give to the providers much faster than some of the other things that we're going to perform in the laboratory. Okay, so after reporting out that gram stain, there are a number of other tests and downstream work that goes on with these positive blood cultures that can help provide even more information to the clinical team. One of the things that we can do is classic culture methods, where we can take that blood broth mixture, we can put that on agar plates, and incubate these in the appropriate environment to wait for bacterial growth, which usually at least is an overnight incubation. So after a day, we can typically see some sort of growth on plates, like you can see here. And once we have growth of the organism on the plate, we have methods in the laboratory where we can identify that within the same day and report that to the healthcare providers. After identification, we can then do further testing for susceptibility testing results to let the healthcare providers know the susceptibility profile of these organisms. That takes at least another incubation day to perform this testing. So anywhere from about 2 to 3 days, using our classic culture methods, we're able to provide both the identification and susceptibility profile of the organism that we've identified in the laboratory. So you can see that still takes some time to get that information to the healthcare providers. So one area of major growth in the microbiology laboratory is the implementation of new technology and rapid testing for blood cultures, to help get that information out to the providers faster than it takes for those classic culture methods. So in addition to this culture testing, that our laboratory also utilizes a number of assays that can get some of that information out quicker, in the same day as a positive result. One of the common methods is through polymerase chain reaction, PCR. There are a number of assays now that can perform PCR on the positive blood broth that immediately comes off the instrument. It doesn't require growth. We're looking for nucleic acid, genetic material of the organism present in that blood culture bottle. We can look for the common organisms that are causing bloodstream infections, and we can also look for resistance genes so that we can report out things like methicillin-resistant Staph aureus and vancomycin-resistant Enterococcus. We can do that within just a couple hours of that blood culture bottle being positive. There are also new assays as well that can provide more information on susceptibility testing, can actually provide a limited susceptibility profile in the same day that the bottle flags positive rather than waiting for actual growth of the organism. There are a few different methods and technologies that have been implemented in laboratories that can do that as well. So in the same day that a blood culture is positive, the microbiology laboratory now has a lot of tools that can get this information out very, very rapidly to help impact patient care as soon as possible. So that's a quick overview of what the laboratory does with these positive blood cultures and the tools that they have, and all of this work and excellent equipment and ability to rapidly report out this information is really all dependent on the idea that the organism that has been identified in the bottle in this positive blood culture is the true cause of the patient's symptoms. And that's where, I highlighted in the beginning, what we're really testing for is a bloodstream infection. We're really only be able to identify what grows in the blood culture bottle, but we're not tying that back to any sort of, we don't have a test to be able to tell us what is significant or which organism is actually responsible for causing the symptoms that this patient has. And that gets challenging when we start to talk about blood culture contaminants. I'm sure most of the participants are aware that there's an abundance of bacteria both found in the environment and on the skin of both the patient and the collector. Some of these common organisms are different species of Staphylococci, Corynebacterium, and Bacillus. And if we don't perform proper collection techniques, it's very easy to introduce these organisms into the blood culture bottle. And as I described, these bottles are designed to help facilitate rapid growth of a variety of organisms. So introducing these organisms into the bottle is going to allow them to grow and cause these blood culture bottles to be positive, which these false positive cultures that are due to environmental or skin microbiota have there's a lot of documentation and data out there about how they increase healthcare costs and increase hospital stay for patients. And one question that we commonly get is if we know which organisms are commonly found on the skin and in the environment that can cause these contaminants, which we do have a good list of those that we commonly see, why are we not able to just ignore those? And the complication is the fact that in the right patient host, depending on what other immunocompromising conditions they have or other disease states they have, these skin microbiota and environmental contaminants can also be the cause of disease in these patients. So when we see these organisms, it can be very difficult to determine whether or not this could be the reason for the patient's symptoms or could just be a result of blood culture contamination. So one of the ways that the laboratory tries to help report this to the healthcare provider and help them make this interpretation when we see these organisms is by requesting those multiple draws to help kind of differentiate this fact. In many cases, when a blood culture contaminant is introduced into the blood culture bottle, it's a result of inadequate skin preparation or lack of use of sterile equipment or some sort of introduction of environmental bacteria into the venipuncture site, and we get that in that positive blood culture. But if we ask for a second site and ask for that whole process to be performed again, it's not likely that we're going to see the same organism that would be detected through another blood collection process. If we see it coming from these two different sites, it's more likely that this is actually found in the patient's bloodstream rather than due to a breakdown in the collection process. And so that's one way that we can help identify, at least from a laboratory definition, identify these blood culture contaminants. And this is something that healthcare institutions monitor closely and try to release and educate anyone in this blood collection process. This is just an example of one way that data can be tracked and displayed by looking at blood culture contamination rates. This particular display is showing on the right-hand side the total number of cultures that are either collected from peripheral or line draws. And then the lines going across over the 2-year period is tracking the contamination rates. And you can see that for the most part of this 2-year period, as I mentioned, the line draws, those intravascular devices, are responsible for higher rates of seeing those common blood culture contaminants. And so this can be displayed differently depending on your institution's policy and data gathering processes, but it is very helpful to utilize and identify areas where further education or further investigation is needed to help maintain these contamination rates at an acceptable rate, which by current guidelines is below 3% of the cultures drawn. Okay, so with blood culture contamination, this is really highlights the impact that the collector, the phlebotomist, can have on this process, and helping to improve patient care is by really focusing on the quality of the culture that's collected. It's important to make sure that we have thorough disinfection of the collection site. We're going to talk about some disinfecting agents, and then also an area that is a common source of contamination as well is cleaning of the tops of these blood culture bottles. Some of these, depending on the manufacturer, have some sort of cap on the top of them, but they're not immune to the ability of environmental organisms to actually be on that on the top of the blood culture bottle. So making sure we're disinfecting both the skin site as well as the blood culture bottle. As I mentioned, the contamination rate is the current guidelines are that this should be below 3%, but with current advances and new methods of collection and devices that are available, there are some suggestions that we could lower this even lower than 3%. And I'll mention that here in a couple slides as we talk about some of those new devices. Okay, so with blood culture contamination and skin disinfection, a common area of question that we get and ask for advice is there are multiple disinfecting agents. Which one is the best one to use, and which one provides the best ability to help reduce contamination? And I have just kind of a slide of the common ones, the common agents that are used here that we can go through and talk about. One of the common agents that's used is CHG, chlorhexidine gluconate, is a common agent. The way this works is it's disrupting cytoplasmic membranes and denaturing proteins to kill the bacteria. It's very effective on gram-positive bacteria, which is the most common organism found in part of the skin microbiota. So it's great in terms of skin disinfection. It also has an advantage compared to other agents that it does not need to be washed away after application, reducing that step. One of the disadvantages is that it's not as effective against gram-negative bacteria, which again is not the primary component of skin microbiota, but it does have a little bit more narrow area of activity compared to some of these other agents. You do have to wait for proper contact time and air drying before proceeding with the collection. And a big disadvantage here is that it's currently not recommended for patients less than 2 months of age. And I'll talk about that here, I think, in the next slide a little bit more. Another agent is some sort of alcohol-based disinfecting agent that's commonly used. They have a very similar mechanism of action compared to CHG. They do have the alcohol-based agents do have a little bit wider area of activity of different organisms relative to CHG. A big concern with the alcohol-based, depending on the patient population that you're using, is that it is known to have skin reactions and irritations, as well as potential for systemic absorption. So it is a consideration that institutions have to consider. The final agent is iodine, which can be found in a couple different forms, either a polymer carrier that helps with solubility of the iodine, or an iodine tincture. The iodine is the active agent here. It forms complexes with proteins and lipids and impairs their function. So a slightly different mechanism of action compared to the other two agents. What's been found so far in head-to-head agents, because there are different formulations, that iodine tinctures appears to be superior at reducing blood culture contamination. The big concerns with iodine is that there are patients with allergy. There's a concern in infants, its use in infants with the association of hypothyroidism, and really a big thing in terms of a workflow perspective is that you must wash away the iodine before proceeding with collection. And there can be longer drying times compared to some of the agents as well. So with these agents, we do get questions about what is the most effective, what should be implemented. The reality of it is there have been head-to-head comparisons that have suggested that certain agents are maybe slightly have reduced contamination rates than others. Things like alcoholic solutions, whether that includes CHG or not. CHG also does not, as we mentioned, does not need to be wiped away. And even though it has disadvantages that it might not be as widely acting, it really is acting on the type of bacteria that we would see with skin microbiota. Iodine, as we mentioned, is slightly less user friendly because you have that extra step of wiping away. But the reality of it is these can all be effective. The big recommendation that we make is really trying to look at your collecting staff, the workflows that you have, and make sure that you're just optimizing it for your patient population and your current workflows. And the biggest thing, no matter what you're using, is just making sure that you're following whatever the manufacturer recommendations are, whatever data we have, so that the agent is being utilized appropriately. Appropriate contact times is the key thing there to make sure that you have sufficient disinfection of the site. So this is just a quick overview of what a possible workflow could be. Looking at for patients greater than 2 months of age, you might use a 70% isopropyl alcohol as a step 1 disinfecting agent, and then follow that with a step 2 second antiseptic. Here is iodine, but you could use something else. And again, just making sure that you're following the amount of time that this should be, the contact time, as well as allowing for air drying, as well as any steps that are required for wiping away if you're using iodine. The challenge here, going back to pediatric patients, we've mentioned, I said that CHG is not recommended in infants less than 2 months of age. This has to do with an increased concern for skin irritation. This is particularly the very young, even premature babies, due to just lack of development of all of the skin layers that can lead to worsening skin irritation risks compared to others. Currently, it's not recommended. There is some data that potentially this can be utilized in certain patient populations, but I would really encourage you, just depending on the patient population that you have at your institution, really to evaluate that at an institution specific level to see if that's something that could be used. The current protocol here is just a 60-second scrub with 70% isopropyl alcohol, and avoiding the use of some of these other secondary agents that are not recommended. Okay, and so then I do just want to talk about, kind of as the last topic here, we focus so much on proper skin preparation and disinfection. Even with the best technique, it's still not sufficient to completely eliminate blood culture contamination. Even the best skin disinfection is not going to eliminate that entirely, and that's because some of the organisms that are found as part of the skin microbiota are not in locations where they're going to be susceptible to these disinfecting agents. They can be in things like hair follicles or deeper layers of the skin, where they're not going to be coming in sufficient contact with these agents to be killed. And so even with this best effort, when a venipuncture is performed and a small skin biopsy is taken into that needle and eventually transferred into the blood collection device, the blood culture bottle, any bacteria that's present in that small skin biopsy is able to cause blood culture contamination. And so with that idea in mind, there have been developments of devices that have tried to get around the fact that that initial volume that's taken from the venipuncture it really should be avoided. We don't want to put that in the blood culture bottle, because that's the part of the blood that's really responsible for that contamination event. And so, excuse my little animation here, my depiction of a diversion device here in this blue square. If we can actually remove that initial volume that's collected from the patient that might be containing that skin plug, the small number of organisms that is responsible for the blood culture contamination. And once that initial 1 to 2 mils has been diverted, we can then take the subsequent blood that is being collected from the patient and make sure that that's what's put into bottles, and that has the ability to then further reduce contamination rates. And now that we've had these devices available to different institutions, we're starting to accumulate quite a bit of data. I tried to summarize that here with a few different studies that have been performed at different types of institutions and different types of environments that have either compared, before and after implementation of these devices and looking at contamination rates, or some of them have even drawn one set with a diversion device and in the same patient then also done their routine method without the diversion device and compared contamination rates. And what you can see is that really across the board, what we're finding is that use of these diversion devices can reduce blood culture contamination rates that are reported. And a particular area of growing literature has been in emergency departments where this can really make an impact. And so we have a good amount of data that's now said that these do reduce, they do have the ability to reduce blood culture contamination rates that are reported, and really the main difference is the amount of reduction that you're going to see. That appears to be more institution dependent than across the board. So there are some things that you have to consider when looking at these devices. Really, the evaluation that needs to be done really needs to be a combined effort between staff that's performing the blood culture collections, as well as the microbiology laboratory, so that we make sure that we get the appropriate data and the appropriate people involved to make sure that we're studying the effects of these devices appropriately at different institutions. And just things to consider that have been brought up by a number of the studies that have been published at this point is looking at target areas within the healthcare institution. Are you hoping to implement this across your entire healthcare center, or are there certain areas that have higher rates than others that this could be more useful? These diversion devices do increase the cost and potentially decreasing efficiency. Some of these are a little bit difficult to get used to and are another piece of equipment that the staff has to deal with. So really making sure that you're utilizing them efficiently if you are going to impact them. And then just the impact of there are different devices that are available, so making sure that all of them are evaluated, so that you can really understand which type of device has the best ability to be implemented in your institution specific collection processes. So I will conclude there and just leave you with a couple important points that I hope that you take away from this presentation. One is that blood cultures are an important tool for the management of bloodstream infections. They can provide really valuable information to the healthcare provider. The clinical laboratory has a number of tools now to rapidly identify organisms associated with bloodstream infection and get this information to the healthcare provider as soon as possible. But really, for them to be useful, it requires really good teamwork and collaboration between the laboratory and the collecting staff to make sure that the proper collection techniques and the proper specimen is submitted to the laboratory, so that we can, as a team, really provide the best information and results possible back to the healthcare provider, so that we can help and impact patient care to the best of our ability. So I will stop there, and I will take a look here at some of the Q&A. Okay, so I can see we have a number of questions. I will read through them, and Sierra, just keep let me know. I'm not exactly sure where we are on time.
Yep, we have about 2 minutes left. So if you
Okay.
want to go ahead and answer what you can in that time, and
Okay.
then you can submit questions via your evaluation if they do not get answered today.
Perfect. Thank you, Sarah. Yeah, so I see one question about why needle sticks should be performed in two different anatomical sites. It really goes back to on the microbiology side of things. That's really helpful to utilize that as a way of creating a laboratory definition for blood culture contaminants. Um, Is there a recommended time for cleaning of the bottle tops with alcohol? That's a great question. That goes back to really the manufacturer's instructions. There is a lot of literature out there about contact time. So that's really the recommended same thing in terms of skin disinfection, utilizing the appropriate contact time that's recommended for whatever agent that you're using. Is Mayo routinely used diversion devices? It's been evaluated. Thank you for that question. I did mean to mention that it has been evaluated, and we're still kind of evaluating that data to figure out how best to utilize them. Yeah, that's a good question. Thank you. How soon can we draw the second set of blood cultures? Yeah, that's a good question as well. There really isn't. There used to be kind of more thinking that we needed to space these out in terms of different conditions, things like endocarditis. But really now, concurrently drawn, there really isn't as much of a concern about the time in between collections. They can be collected as soon as the first set is done, just as long as this actually is a second site of collection. I
think we'll plan on concluding there, Dr. Streck,
Okay.
with it being noon. So thank you everybody for participating in today's phlebotomy webinar on blood cultures. As I mentioned, if your question was not addressed during today's session, or if you have additional questions, please include them in your evaluation. You may reference the link in the chat to access the evaluation now. Laboratory credit is extended for this program. Upon finalizing your evaluation, you will have the option to claim credit and print your certificate. If you had registered for this webinar and joined by phone only, please email us at mcleducation@mayo.edu if you do not receive the evaluation. As a reminder, this program was recorded and will be archived on our website in a few weeks. Thank you again for joining us for today's webinar, and have a great day.